Thanks so much. I have to make two disclaimers from the beginning. I'm sorry to have to use my sexy exorcist voice today. It's not natural, but that's what I've been given. And the other thing is, this is an oncology talk where I'm not going to be giving any Kaplan-Meier curves and no signaling pathways. So let's move ahead. Today I'm really talking about cancer health disparities, not just breast cancer, and I'm going to be particularly talking about New Haven. Just want to start out by saying I came to New Haven in 1981 to start my internship and noticed at that time that there were differences in outcome, particularly with cancer, between black patients and white patients, although the term cancer health disparities was really not coined till 1999 when Harold Varmus developed that term when he was director of the NIH. And I'm going to start out defining cancer health disparities, talking about it nationwide a little bit, but then really get into discussing what we have going on in New Haven. You can see the NCI has their own definition of cancer health disparities, and this was issued by the NCI, National Cancer Institute, in 2007. But keep in mind when Nixon, by Nixon I mean Richard Nixon, former president, declared his war on cancer in 1971, there actually were no disparities between blacks and whites. And that was really seen in 1975 and has increased over the past, really increased until the mid-1990s when it started to decline. But keep in mind that health disparities now are greater than 1975. So we still have a long way to go. This slide really talks about what the problem is, and you can probably see that the cancers that are really responsible for the health disparities are the three most common tumors that you see in men and women, specifically colorectal cancer in men and women, breast cancer in women, and prostate cancer in men. In 2009, the American Society of Clinical Oncology convened a meeting, at which point they drafted a response about the emergency in cancer health disparities. But keep in mind, this is a full 19 years after disparities peaked, and this was published in the Journal of Clinical Oncology. I'd like to move ahead now to New Haven and talk a little bit about New Haven as a city. And this is a great place to look at health disparities for a number of reasons. First of all, there are three major ethnicities in New Haven, and whites are in the minority in New Haven. You can also see New Haven meets the definition that is in the literature of a poor city. Poor cities being cities that have either 20% or greater who live below the poverty level, and we meet that landmark. And also you can see that it is a city where there are a lot of populations, a lot of people from other countries, with 28% who speak languages other than English at home. I'd like to refer you to the 9% unemployment rate. In 2006, that would have been alarming. This year, it's really pretty good. It's actually so good that the Brookings Institute issued a report, and they named New Haven in the top 20 cities for being able to weather the recession. Well, why is that? The big employers in New Haven are recession-proof. Yale New Haven Hospital, Yale University, and Hospital of St. Raphael. So we've been stable. But keep in mind, healthcare is a really important job opportunity and area of employment in New Haven, and there are a lot of doctors and a lot of health professionals in New Haven. Okay, here's really New Haven as compared to the outlying towns in New Haven County. You can see New Haven, white persons are in the minority, and let's compare that to further out on the shoreline, Madison, that's 95% white. All the other cities are basically white, so New Haven is unique in New Haven County. I'm going to talk a little bit about our community. Since 1995 at Hospital of St. Raphael's, we've had a cancer clinic, and as part of that, we have an outreach program. We go into the community, myself, an outreach worker, and a case manager, trying to enroll people in screening programs, specifically the early detection program for breast and cervical cancer. We have a new colon cancer, colorectal cancer initiative. And we also get out there to try to teach people principles of cancer control and risk reduction. We partner with the Salvation Army, both in New Haven and in Hamden. Here's our outreach worker, Janet Brown, trying to enroll someone in mammographic screening. And we go to places where patients traditionally or people do not get medical care, such as soup kitchens and homeless shelters. And we also have in-reach programs, a patient navigator, and that really is part of a feeder for us for the clinic. So I want to move ahead to our information from the clinic, but before I start going into what we found in the Father McGivney Clinic, just say what the American Cancer Society issued in their report on cancer health disparities in the year 2004. They said there are 3 particular areas that are responsible for disparities. One is structural disparities, things like geography and finances that keep people away from getting their treatment. Then there are physician disparities, that physicians may give completely different treatment to patients who are in underserved populations as opposed to more affluent communities. And finally, there are patient reasons, lack of trust, and that patient-related fears of being in cancer clinics that prevent them from getting cancer care. So what we did was we reviewed 200 active patients at the clinic. I eliminated patients who had primarily hematologic diagnoses or people who had incomplete information. And part of the reason why this is a great place to look at the charts is because some of these disparities that were cited in the 2004 report are really not present. Geography is not that much of an issue in New Haven, where many patients are within walking distance of a lot of medical care. And as far as finances, we don't turn anyone away at Hospital of St. Raphael's because of the hospital mission, although people who are uninsured need to pay a little bit according to what they have each week. So those barriers were eliminated, and I'd like to say, since I have both a private practice and I am the physician in charge of the clinic, practice in both places according to NCCN guidelines, and that there really is not anything that is not within those kind of confines. And as far as patient factors that prevent people from getting care, that's one of the things that I looked at a little bit in our analysis. So let's move ahead. Look at the average age of patients that came to the clinic. 56, that's to be compared to the 66 years of age that's seen in the SEER reports. And the last report from the American Cancer Society in 2006 showed that the average age at death of cancer in the United States is 73. So these patients are definitely younger. They are predominantly female, which is different from what you see in the country. But you can look here at the numbers. This pretty much mirrors what you see in New Haven. And that's also something that makes this a good place to look at some of the results, because it's not just a clinic that serves ethnic minorities. It really is a clinic that serves everyone who is poor. Most of the patients are citizens, and a large percentage of them are English-speaking. About 50-50, half and half. Some have welfare, and some are self-pay. That means completely uninsured. The sites of cancer I found in this clinic population are pretty similar to what we see in the United States, with some big differences. Lymphoma in this population is much more prominent than we see in a general cancer population, perhaps reflecting the younger age of the patients. And prostate cancer, which is really common in the general population, is not as common in the clinic setting. I tried to think about why, and that might be because when people get Medicare at age 65, they don't need to go to the clinic, and a lot of them go to the VA if they're veterans. But we did not see a lot of prostate cancer. This slide really says it all. About 64% of these patients presented with advanced stage disease. This is very different from what you see in affluent communities. A recent report showed for colorectal cancer in affluent communities, less than 20% present with advanced disease. As far as breast cancer in the United States, 70% have early stage at diagnosis. So these patients came in with really advanced disease. But as for patient factors, 81% received treatment and 72% received chemotherapy. So these patients were compliant. They did get treated. There are numerous reports in the literature about patients in poorer settings not getting chemotherapy, not getting adjuvant chemotherapy, not getting adjuvant radiation. These patients were treated according to NCCN guidelines, although I did not see whether they received full doses or how many cycles of chemotherapy. But the other thing I want to show you is, if I can figure out how to get the arrow down here, that the majority of these patients, despite their young age, had one or more major comorbidity. And my next focus in this talk is going to be on those comorbidities. 17% of the patients had hepatitis B, hepatitis C, and or HIV. And these conditions were often diagnosed at the time of their cancer diagnosis. These are not people who came in with HIV-defining illnesses or people who came in with hepatoma. These are people that in their evaluation, either they had some mild cytopenias or abnormal LFTs, and as part of their staging evaluation, we realized they had a virus. And this is really important. This is not something that is discussed in the disparities literature, and it really can alter outcome. Most of the chemotherapy drugs are metabolized in the liver. If someone comes in with untreated hepatitis, it may alter the doses that can be delivered. And people who have HIV are going to need to start on their antiretroviral therapy, and it may cause some delays. There are the common comorbidities that are described in the literature, hypertension and or diabetes, which may be a factor, and this is very prominent even in this young patient population. But some of the other things I wanted to talk about is substance abuse, psychiatric disease, and social problems. 3% of our patients were homeless at time of diagnosis, and that only are people who really lived in shelters. There are patients, many of them, who have sort of transitory living arrangements. They go from family member to another family member. It's really hard to contact patients. It's really hard to convey information when people don't have phone numbers or they're living with different people. And also, we saw a percentage of patients who had recently been released from prison. The cancer care in the prison is provided by UConn, but people who have recently been incarcerated are often very suspicious. I'm currently taking care of someone with locally advanced lymphoma. There's a warrant out for his arrest. He is afraid to get his picture taken. He can't get Title 19 without a digital photograph. So we can't get payment for his treatment until he consents to get his picture taken. And he's really afraid that by having his picture taken, he's going to be picked up by the police. Wanted to highlight cervical cancer, and the reason why I wanted to talk about cervical cancer is this is a cancer that we have, first of all, a vaccine, and second of all, if diagnosed in early stages, it's really a curable disease. And in New Haven, since 1995, Hospital of St. Raphael's has had an early detection program funded by the CDC through the state of Connecticut. Yale New Haven Hospital has one. That means everyone who is female above the age of 18 is entitled to free cervical cancer screening. And even undocumented women can be diagnosed on this program, although they can't receive treatment. And despite that, I'm currently taking care of 5 active patients in this small clinic that have stage 3B or 4. And that is a very alarming number. The patients range from age 27 to 58, and I think people realize stage 4 cervical cancer is an incurable disease. 27-year-old woman. They are all U.S. citizens, and with the exception of one who has lifestyle reasons, perhaps for not accessing health care, one thing I found in these women is that they've all been in healthcare environments, but basically they're with either a spouse or a parent. Some of the women talked to me about going to the VA once a week with their spouse, but they didn't get their own health care. The reason why I bring this up is it's an important area for intervention. I could think of a targeted intervention where someone is coming with a caregiver, where someone really could think about the health of the caregiver, because this was one of the big factors in these women not getting pap smears. So who are the groups that are at risk for cancer health disparities in New Haven? Well, they're people of low income, ethnic, and racial minorities, but I also want to say white people who are in the minority in New Haven are also at risk. Although the numbers were small, it certainly looked like they all presented with late-stage disease and had some similar comorbidities. The only group that seemed to fare better was the very small number of Asians who came to the clinic. Undocumented residents, for obvious reasons, have problems where they fear being turned into the authorities. And Hispanics, which are the fastest growing population in New Haven, 20 years ago, Hispanics were mainly Puerto Ricans, but now these are people from Mexico, Colombia, Nicaragua, Peru, and they have a different kind of, they certainly have different insurance status. There is an effect that's described in the literature called the Mexican effect, where they show that Mexicans, when they come to the United States, the first year they have better health-seeking behaviors than they do when they've been in this country for 10 years. They come to this country, and then within 10 years, they pick up things like substance abuse, alcoholism, tobacco, poor diet, and lack of exercise. And actually, I was surprised to learn that Hispanic women of any group, recent immigrants, have the highest rate of exercise of any women. And that's probably because people who are from more rural environments expend a fair amount of energy cleaning and doing chores, which our modern conveniences have kind of taken away from American women and American men. Sorry. Let's talk about some of the barriers to receiving optimal cancer care. We talked a little bit about hepatitis and HIV. While it doesn't prevent people from getting care, it may prevent people from getting some of the benefits of care. those who are homeless and involved in the penal system have many problems and issues around trust, although the clinic has been present for 15 years now, and we do see a lot of people who are in these environments and they do get care. People with psychiatric disabilities and people who have substance abuse issues, particularly those with dual diagnoses, have very major difficulties getting treatment. Even people who are not active substance abusers, if they have substance abusers in their families, their medications may be stolen, all the benefits that they receive while they're ill may be taken from the family members, and it makes it really, really hard. With all the discussion of healthcare reform and talking about, problems with people who are uninsured, I've seen very little talk about the services that they're going to provide for substance abuse and for psychiatric care. And this is really an area that, as part of medical oncology, is not an issue we generally discuss. I know in the disparities literature, that's really not an issue that's discussed. But at least in my findings, it's there, and it's something we need to deal with. And I remember even trying to get someone on a clinical trial and then trying to get him off of cocaine before he got into the clinical trial, and there was no ability to do so. So in my conclusions, there's some good news here. Most patients do receive treatment and receive chemotherapy. But the patients are young and they present with late-stage disease, which is very bad. They have serious comorbidities, and in order to actively treat their cancer, some of those comorbidities need to be addressed, and that the social issues, despite maybe not having some of the barriers that were discussed in the American Cancer Society programs, they do impede treatment and screening programs. There's absolutely no coordination in a city of this size between the various agencies. Someone can have a hearing at the Housing Authority, hearing with Social Security, and chemotherapy all scheduled at the same time by 3 different agencies, none of whom know about each other, and so therefore the patient may be non-compliant with 2 of those agencies. And that's a big problem, and particularly in this era of a lot of abilities electronically to communicate, it's a problem with reduplication of services. I'd like to summarize, talk about some of the future strategies. We need to coordinate these services. There's no reason why they can't be, but this is something, we have a great medical school here with a lot of information and talented people, and there's something about this young age that is very different from the other populations, and that their stage is so late. And it does suggest that there is an area of both epidemiologic and biologic factors that need to be investigated. But I'd also like to say that in order to make progress, the answers are not going to come from a group of people sitting in Bethesda. They need to come from the community, and they need to come from people who are actively taking care of these patients. I would love to say that chemotherapy is going to be the answer, but right now in 2009, many of these cancers are best addressed by early detection or modification of some of the risk factors. So we need continued outreach. We need community involvement. The World Health Organization has estimated that 40% of all cancers worldwide can be eliminated by risk reduction. So that should be an important part of oncology. And for my final conclusion, we need to have the community involved to decide what are these effective strategies to reduce cancer disparities, and to have a multi-tiered kind of response where you have people from the community and people who have both translational and statistical skills in order to develop effective programs. I'd like to thank the Breast Cancer Alliance for some grant support, and Jennifer Porto, my case manager, for her assistance. Thank you very much.